cardiac device and cardiac replacement therapy. So the first question is, a 45-year-old woman was transplanted 90 days ago. 2 weeks ago, mycophenolate was discontinued due to diarrhea and anemia. She reports feeling unwell the last 48 hours. She has a low-grade fever, fatigue, and palpitations. She has right bundle branch block with intermittent high-grade AV block. The biopsy confirms severe rejection. At this point, you should consider which? A, plasma exchange, B, a pacemaker, C, methylprednisolone, D, coronary angiography, or 5, E, rituximab. Okay. Next question is a 33-year-old woman with negative serology for CMV, toxo, EBV, who underwent transplant 7 months ago. She did well in the early transplant period, but now presents with fever, aching, elevated liver function tests, and leukopenia. The most likely cause of this is A, TB, B, toxo, C, EBV, D, nocardia, or E, CMV. Okay. A 61-year-old cardiac transplant recipient, 5 years status post-transplant, presents with syncope. Evaluation demonstrates frequent runs of non-sustained ventricular tachycardia. A biopsy was done and there was no evidence of rejection. An echo shows akinesis of the anterior wall. The most likely diagnosis in this case is which? Humoral rejection, antibody-mediated rejection, transplant vasculopathy with MI, cell-mediated rejection, or CMV myocarditis. Okay, I want to welcome my friend Dr. Alfredo Clavel to come speak to us. Alfredo obviously works with the heart failure group, and in particular works on the heart transplant team. And he's given this talk for a number of years now to kind of talk us through all these rejection, funky things that happen that most of us don't have to deal with. So thanks, Alfredo, for being here.
Good morning. Thanks, Steve. Doesn't look like we have a lot of work to do. Preliminary review of those questions looks like you guys already kind of know a lot about this. We're going to really divide the talk in two sections. I'm going to first talk about mechanical support, which I think is a growing part of our practice, and I think you would be expected to know elements of this. And I will highlight to you. You will hear me speak slowly because I tend to speak very fast, and really slow down when I want to drive a point across that I think you ought to really remember as we move forward. These are the learning objectives that you see here, and these are actually what the board anticipates you need to know as part of this particular segment. And we're going to talk about mechanical devices and surgical treatment options for heart failure patients. We're going to really hammer indications for LVAD, where is there a role, and where should we consider heart transplantation. We're going to really talk about complications with LVAD. That is really something you really need to be familiar with. Beyond the boards in your clinical practice, you're bound to find people with this growing technology. And then we talk a little bit about immunosuppression and other sort of management issues, common management issues in transplant patients. Also a growing population that you're bound to find in your practice. I think I'm going to start with taking off where Barry and Naveen talked about, and really emphasize to you today that we're going to be talking about stage D heart failure. These are not your run-of-the-mill patients. They are a growing population by virtue of the fact that heart failure is in an epidemic state. But these are patients who, despite our best efforts with all of the armamentum that you have heard from Naveen and Barry, we are not able to get them out of a very debilitated and symptomatic stage. Just illustrated here in more detail, you can see that we're talking about patients who are on optimal medical therapy, which we have done lifestyle modification, perhaps cardiac resynchronization, high-risk surgery has been considered, and they're on everything. And now we're talking about patients who are either in the ICU or requiring outpatient inotropes, or they're in and out of the hospital, very limited, and we'll start to talk about VAD transplantation. So we're late in the process here, and we can't seem to make our way back. And it's important to recognize that this population is a high morbidity, high mortality population. These are a number of clinical trials, that placebo arms of clinical trials that have looked at this type of stage 3 or 4, class 3 or 4 population, as well as class 4 patients, as well as registry studies that have looked at real-life practice mortality in patients. And you can see that the 12-month mortality is a 30% mortality and a very high rate of hospitalization and rehospitalization. How do we define this population? How do we say, okay, this patient has been coming to my office for years. What are my clues that we're headed in that direction? And we like to sort of, these are the things we think about in practice. Somebody who perhaps responded to a CRT, but now we have lost that response. The cardiorenal phenomenon, when you start to see that they're increasingly congested, you're increasing diuretics, and all you're accomplishing is a rise in creatinine and BUN. Cachectic, they're losing weight. Cholesterol is low. You can see that they have lost muscle mass, and then they have had increasing hospitalizations where they had been stable before. I think this is a really critical one when you have to start backing off on medications because of blood pressure or renal dysfunction. Or echocardiography mediated, you start to see a rise in pulmonary artery systolic pressures driving the point of that transpulmonary gradient, or a fall in their peak oxygen consumption where they had been doing reasonably well compensated, and now you're looking at that sort of type of data and seeing that there has been a progressive decline. What's the magnitude of the problem, and why would we need to consider mechanical support? Well, you can see here the number of new heart failure cases a year. These are the number of, within that population, the number of people who would be appropriate candidates for advanced therapies, the stage D patients, 25,000, and these are the number of hearts that are available for transplantation. So less than 10% of patients can actually benefit from transplant. This is all comers. And so we have been saying for a while that transplantation, although remains the gold standard, and we'll talk about it in the second part of the lecture, really is not a good solution for this problem because the number of donors is unlikely to increase. As you can see here, that figure has been stable. And so what are our options besides transplantation? Well, we have options such as the LVAD, which we'll discuss in more detail, total artificial heart, which would be used as a bridge to transplantation, and then things that should have been covered already in previous lectures in terms of when do you consider high-risk valvular surgery or percutaneous surgery or high-risk revascularization for those patients who may benefit from that. And that's outside of the scope of my lecture. We started with this large sort of what we call the Maytag device. This is actually probably less reliable than a Maytag machine nowadays because it's a pulsatile device with valves in the inlet and outlet, and these devices inherently will always fail, usually within the 2-year timeline. So they were good to get us started with this process, but they weren't good long-term solutions. And now we're pretty much gone to continuous flow, which brings in a new set of problems and issues that we'll discuss. But these pumps are very durable. We have had patients out 7-8 years supported with this device, and so mechanical failure is no longer an issue. This is what that pump looks like, and it is getting smaller. Some of these pumps are even just attached at the apex with a small cannula to the aorta, and then the components remain external. The things that drive the power remains outside. when do we think about LVAD therapies? And I think it's important to keep this in perspective. We consider what we call BTT, or bridge to transplant. Those are patients who we have evaluated for transplant and feel they're a good candidate, but of course, because of the lengthy wait, we feel that supporting them with the LVAD is the best way to get them to transplantation. And then a growing number of the population, and I think if you look at our practice, probably a good 2/3 of what we implant are destination therapy patients. Those people, usually age-related and comorbidities that lead to the use of this device as their treatment for end-stage heart failure. And those are patients who have been on optimal treatment that remain pretty symptomatic, and they're not candidates for transplantation. And a lot of the data that I will present you will be on the DT population, which is really what we're going to talk about. And these are the key things that usually lead to thinking about DT. When you look at most patients who have been implanted in the registry, we're talking about advanced age, comorbidities, usually obesity, diabetes, renal dysfunction. Fixed pulmonary hypertension is a significant problem that this device can help with, and patients who are not good candidates for immunotherapy, active cancer, or a patient who's recently been treated for cancer, and a patient who prefers mechanical support, and this is a growing population as opposed to the risk that comes with transplantation, which will expand. You'll hear about Intermax classification. Again, this is the registry that keeps data of all the LVAD information that's available, implantation, the circumstances, and I think I'd like to summarize this busy table, just pointing out to you that most of the studies have looked at class 1 or class 2. So again, very sick individuals, either in the ICU setting, who are failing despite escalating support, or we were able to stabilize initially and now they're falling despite being on inotropes and escalating support. So class 1 and class 2 is the emphasis on the majority of the early studies, and more recently RoadMap studies and other studies have looked at class 3 and 4. These are patients who have survived the initial event, but they remain quite limited. We call them the walking wounded. They may be on inotropes, or they're just in and out. They have been on inotropes, but even after coming off of them, they're not doing well. And then these are your sort of the majority of the what we would call the low class 4 and class 3 patients, 5, 6, and 7, where we really don't have any experience in the use of LVAD devices, and they're probably not indicated until more data is available. So pop questions for the boards is who's our candidates for LVAD. These are very sick individuals. It's really where we have the bulk of the evidence, and those people where we feel without further intervention they will end up here, and those are people that we can consider LVAD therapy. When we talked about the patients who are acutely decompensated, and Naveen talked a little bit about management, it's particularly important in this patient population, as it will become obvious to you as we talk about potential risk of intervention. And that is, we hope to achieve a cardiac index of over 2.2, a wedge below 20, a right atrial pressure below 15, and a systolic blood pressure above 85, because these are things that are associated with better perfusion. And so you want to see improvement in that function, so a timeline of days to optimize patients before device implantation, because that improves your post-surgical survival. So important to recognize what are the parameters where you want to be in. If they present to a clinical scenario and the patient is really decompensated, your role is to improve that patient before proceeding directly to LVAD implantation, and that improvement comes in the form of using inotropic support, an intra-aortic balloon pump, ECMO, external type of LVAD devices, and the Impella type of devices we have used successfully to bridge patient to get the patient to the surgical intervention. There's a number of little calculators that have come up to determine risk of patients that are headed towards LVAD implantation. They are all summarized here. I think that the big point to remember here is you're looking at laboratory and hemodynamic parameters that talk about whether there is evidence of organ perfusion abnormalities or organ dysfunction impending multi-organ dysfunction. These are the things that you're looking for with this laboratory data. And you can pretty much, it will give you, depending on what your patient has, you can add all those up. And the bottom line is that the less risk factors the patient have, the lower the surgical mortality, while those patients, as we discussed, who've had tremendous hemodynamic perturbations, who have impending organ dysfunction, tend to have the higher risk. So there's a great variability in mortality and surgical outcomes in patients going to LVAD. And if we can recognize that in clinical scenarios in the boards, then you can really define where that patient should be, how he should be managed. And it all comes back to the rematch trial, and this is now all data. This is actually a pulsatile device was used here, and this was the first study that really looked at this population of patients, moribund patients receiving either LVAD device versus medical therapy, with a significant improvement in survival at 1 year's time. And as I alluded earlier, failure of the device led to no benefit at 24 months because, of course, the device failed and there was not a lot of options beyond that. But we've moved on from that to the continuous flow devices that I show, the HeartMate 2 device. And this here, you can see that compared to that same pulsatile flow device, this device was superior not only in early mortality, but also longevity of the device. And if you look at the comparisons of the two types of therapy, this is pulsatile flow and then continuous flow, you can see that there's consistency in that the continuous flow device is better. And I will talk to you a little bit about complications that you may see here, stroke and bleeding being particularly important in the continuous flow device population, that there's a wash or a little bit of a lesser benefit for that reason. More importantly, you can see here the original data that I show you, the rematch trial, the optimal medical therapy. And what has happened is that as we gain clinical experience and learn how to use, evaluate patients better, optimize patients better, survival has been steadily improving, particularly early postoperative mortality. It's well above 80% in most centers at 1 year, which is fantastic when you compare that to cardiac transplantation. But continuous flow has issues, and I think you have to understand that continuous flow is very different than pulsatile flow because it's very preload dependent. And you will see this, that if we drive the patient out too much, this is going to have hemodynamic consequences. This is not a high-pressure device. I think it's important to recognize that there can be changes in cerebral blood flow regulation. Remember, that's a pulsatile flow-driven regulation, and when you lose that, you can get things that we call like pump head, too much velocity, too fast, too much flow into the brain. Mechanisms that are not well understood can cause the patient to be confused, agitated post-implant, and you have to keep that in mind. That the systemic hypertension is a real problem, and I'm talking about blood pressures just above 100 for the mean blood pressure, because that makes it very difficult for the device to generate flow. By the same token, aortic regurgitation, development of severe aortic regurgitation is also going to cause a significant problem. And then also understand that there's an optimal speed of the device, that if we take too high of a speed of the device, we are going to suck down ventricular wall and create a lack of flow intermittently. So there's a little bit of a component of adjustment and learning how to utilize this device to get beneficial effects to patients. I think that I've illustrated here the Achilles heel of the device. This should come as no surprise to anyone. And if you hear about LVADs on board exams, it would be important to recognize that bleeding, thrombotic events, and stroke are the biggest problems with the device. So think about bleeding, and usually gastrointestinal bleeding, because this device basically shreds your coagulation factors and you get a coagulopathy. By the same token, patient needs to be anticoagulated. It's a big hunk of metal. So thrombosis of the pump is also a major reason for why pumps need to be exchanged, because once it gets there, you can't get rid of it. And lastly, because you're in anticoagulation and you develop a coagulopathy, there's a risk of both ischemic and hemorrhagic stroke. And this is much more significant than those patients who are on optimal medical therapy. Having said all of that, I've already shown you the data on survival, so that's already accounted for all these complications on the summary. There's probably slightly greater risk of arrhythmias And I think that some heart failure, of course, is worse in the optimized medical therapy, and rehospitalizations are worse, though there are different kinds of rehospitalizations, because in this population, the hospitalizations are not necessarily for heart failure, they're for complications. I think this is a very important table that we kind of put together sometime in the back, and it's just to summarize clinical scenarios that you may encounter in the exam and in clinical practice. And so I'm going to go them one by one, and I'm going to slow down a bit here. So what are the things that I told you could happen on an LVAD device? Well, the development of thrombus in the pump or thrombosis. Important to know, usually a late presentation. This isn't something you're going to see immediately after surgery. This is something that takes time to develop. Your cardiac output may still be well preserved. In other ways, early on, you're just increasing battery consumption, but the pump's still able to generate flow. Later on, it could be low. What you will see is a rise in filling pressures, because now the device is not as effective as it was in reducing pulmonary capillary wedge pressures. And I think the sine qua non, the thing that you really want to remember, if you remember anything, is that hemolysis is consistent with thrombosis. The two of them are the same thing. So if they present you a case where you see ongoing hemolysis, T-color urine, is usually Coca-Cola color urine, increase in power consumption by the device, that is consistent with thrombus inside the propeller of the pump. Tamponade is something you're going to see early after surgery, okay? So it's a traumatic procedure. Usually a lot of patients have had previous surgical procedures. Cardiac output is going to be low, as it is in other causes of tamponade. There's going to be equalization of filling pressures, nothing new here. But I think the clinical scenario that they're likely to show you is somebody who just hours after arriving from the OR, massive amount of bleeding from the chest tubes, suddenly the bleeding stopped, the device pulsatility index has fallen. Pulsatility index is what tells us what the contribution of the native heart is doing. When the pulsatility index is low, it means you're not contracting, you're being driven by the device. So when that falls and the bleeding has stopped and you see equalization of pressures, you're talking about tamponade. That patient needs re-exploration. Not to be confused, and this you can see also early, right ventricular failure, and these are the two things you want to distinguish. And the big difference here, I mean, they're all very similar early on. It can also be chronic and persistent, but you're going to see these early on. Cardiac output's going to be low, but it's going to be low because your right atrial pressure is going to be way out of proportion to your wedge. So now the device is decompressing left ventricle, your wedge is low, but your right atrial pressure is high. Your NT-proBNP value may be sky high. And this is a patient who you already knew was going into it with perhaps some element of pulmonary hypertension and right ventricular dysfunction. So usually you kind of have a high index of suspicion for people who are going to get into trouble with RV failure, and you're going to manage that with inotropes and things to try to improve RV function over time. Most important one would be optimizing device to keep those left-sided filling pressures low. And then I think it's important to recognize that hypovolemia can also be a problem. Dehydration, to be more specific, that can happen any time, early after surgery or in the post-dismissal period. The cardiac output can be low, but now the filling pressures are very low, and you may not have access to this, but you have access to examine the patient. Usually your PI will also be low. And this is a patient who probably over-diureses and needs to be back off. Speed may need to be adjusted intermittently. I think you may be asked about why would you consider LVAD therapy. I've talked about the number of very disabling complications and yes, better survival, but the reason we do this is because the quality of life is dramatically better, and there really isn't anything that we have even in the symptomatic heart failure population that provides this kind of benefit. So I think you have to understand that no matter which sort of measurement you look, whether it's the 6-minute walk, a physician's clinical assessment of NYHA class, or the patient's questionnaires, quality of life, there's a dramatic improvement following LVAD support across the board in all patients. And I think that's a big emphasis of this therapy as we talk to patients about it. More importantly, even in the not so sick, I mean, it's pretty easy to go for an LVAD when you're in bed requiring inotropic support and you have no other options. But even in a population of patients, as I alluded earlier, who are the sort of walking wounded, the benefit of the device, both in terms of survival as well as improvement in NYHA class and composite events, the LVAD seemed to be a better therapy for those patients. The only thing that was different was when you look at everything as a whole, it seemed like optimal medical therapy was a better option for patients. And this is something that we haven't quite been able to understand, but for the purpose of your understanding, even in the less sicker population, patients do seem to benefit from device therapy. And so I'm going to move towards transplantation. I think I'll give you a pretty good highlight of the things you need to know when it comes to mechanical support. And I think I'd like to transition into there to talk about how do we decide which way do we go. And so we start with a patient who's clearly very limited, class 3 or class 4, who has now been optimized and we can't seem to improve New York Heart Association class. If the patient improves, of course, you're going to continue medical therapy because it's no longer stage D patient. But if they don't improve, if they haven't had cardiac resynchronizations, this is something you would consider. If the patient does not improve or not a candidate for cardiac resynchronization, now you're talking about evaluation for transplantation or LVAD. That's going to occur at a center who has that kind of expertise. It starts with the transplant evaluation. We looked at everybody and said, is this patient a candidate for transplant? If it's not a candidate for transplant, then you look at destination therapy. And I think it's important to know that the insurance FDA criteria is that these patients need to be this limited. They need to have had optimal therapy for 45 of the last 60 days, and they're not a candidate for transplantation. EF has to be less than 25%. So if this patient's a candidate, you can think of that as destination therapy, or if they're a cardiac transplant candidate, now a bridge to transplant VAD, because we talked about the limitations of transplantation and organ procurement. But I want to emphasize to you another option that I'm not sure will be covered here, but I think is something you need to be aware of in clinical scenarios. If the patient's not interested in VAD therapy, there may be an option to pursue palliative care, and this is an important aspect of care of these patients. So it's not, you're not a candidate for transplant, you're not a candidate for LVAD. We counsel patients regarding how do we move on from here and how do we manage symptoms with the help of palliative care. So think about palliative care when you have no other options, because that may be an included answer in your test. I'm going to switch gears and probably spend the next 10 minutes or so talking about transplantation. We're going to move pretty fast through this, but as I said, I'm going to highlight to you the things that you want to really remember for the boards. The gold standard for cardiac replacement. It's unfortunate that we don't have enough organs. Again, same graph, and those numbers are pretty stable. It doesn't matter where you look. This is across the board. These numbers are not likely to change. I think we're at the maximum of organs that we can get. What are the indications for cardiac transplantation? These are patients, again, who have refractory heart failure, either requiring inotropic support, peak oxygen consumption often below 10 mLs per kilo per minute, or patients who have non-revascularizable ischemic heart disease or highly symptomatic, maybe ejection fraction is normal, and also refractory arrhythmias. And then we talk about relative indications. These are listed on the criteria, but in reality, these are people you observe because there's simply not enough organs to go around. But they're important to look at those clinical scenarios. These are not patients that we will be pursuing cardiac transplantation. Who gets a transplant? Majority of the patients are dilated cardiomyopathic processes, whether it's dilated cardiomyopathy or other inherited type of genetic muscle disorders, myotonic dystrophy, and then coronary artery or ischemic disease, and that isn't changing dramatically. There's always a few other indications, but the majority of the patients are either ischemic or dilated. What are the common contraindications? I think this is really an important thing. The next two slides to know. because these are probably clinical scenarios where they can talk to you about things that irreversible pulmonary hypertension is really important. If you have that, that's a major contraindication to pursue transplant. As is diabetes with severe and organ damage, amputations, kidney failure, those patients are not good candidates. They do very poorly. And then I think the other big one, where they like to show you clinical scenario, young individuals, bad cardiomyopathies, and a lot of psychosocial issues. There's a big emphasis on recognizing that that has even a worse prognosis than some of the other things I've talked to you about. Specifically along those lines, cognitive impairment, patients that really can't manage compliance, psychiatric instability, or a history of drug dependence are really, as you would say, red flags in a clinical history that outcome may be quite poor. And in fact, patients where we have pursued transplantation even with close management of that have had pretty poor outcomes. I talked to you about pulmonary hypertension. This is an all graft, and you can look at, it doesn't matter what the timeline has changed. If your PBR is within less than 3 Wood units, that's going to be your best outcome. And then anything above that, it's going to have a worse outcome over time. That is to say, that's just regardless of treatment, and I'll talk to you a little bit about what we normally would do. So if we detect that sort of pulmonary hypertension with a high PBR, or intermediate PBR, high transpulmonary gradient, high pulmonary pressures, the risk of right heart failure and early death is increased significantly, 30 to 40%. And so the way we go about that is, so we looked at basal reactivity. So you don't want to just get the opening numbers. You want to try different things to see if you can lower that. And if we can lower that, then those are patients who are going to benefit from inotropic support, and we will monitor pressures and try to keep within these goals. So you want your PA to be less than 50, PBR under 3, while maintaining a decent systemic blood pressure and a transpulmonary gradient less than 15. And if you're asked what is the best way to deal with irreversible or significant pulmonary hypertension, the answer is going to be LVAD. That is our best treatment option. So if a patient's a candidate, that is the one thing that will significantly lower pulmonary vascular resistance by virtue of its ability to eliminate the higher pressures on the left side. This is really surprising to me that we're still talking about a 1991 study, but it's still what we use as a cutoff. A VO2 max over 40 reflects patients who are relatively stable on the transplant list, versus those that are below 14 tend to have a much worse prognosis. Now, the caveat here is, and I don't think the last is on the board, but I think it's important to understand that with beta blocker therapy, these curves have shifted down. Why? Because beta blocker restricts heart rate, and heart rate is a major component of cardiac output. So we usually look at peak VO2 below 12, really, for patients on solid beta blocker therapy who have limited heart rate response. I think it's no surprise that transplantation really depends on identifying the appropriate candidates and then managing them. And then I'll expand on the post-transplant scenario. I think it's important to say you list somebody for transplant. This is somebody you're going to follow. You don't wait 2 years and then call the patient to come. This is somebody we're going to be seeing regularly because things can change. Just briefly touching on the status of patients. 1A status, these are people in the hospital. We have a number of people usually waiting in the hospital for transplant. They're either on mechanical support or inotropes. Or 1B, requiring inotropic support. And these are the people who are in the outpatient setting, and then these are the only 2 people that we really transplant. No one really transplants status 2 patients. Moving over towards post-transplant care, I think it's impressive to know that transplant outcomes continues to maintain stable, slightly improve, despite the fact that there's increasing comorbidities. And I'll talk to you a little bit about how the LVAD, RVAD support have changed outcomes. You can see here that for different eras, going back to the 1982 to 91, all the way to the modern era, survival has continued to improve. So cardiac transplant survival is quite good. And again, that's not the issue. The issue is not enough organs. And then when you look at what impact has it had to have all this mechanical support, potential bleeding, sensitization events, you can see that mechanical support, unless it's ECMO, which is obviously the last-ditch resort, the other patients who have been supported with mechanical support tend to fare quite well. So it doesn't have a detrimental effect on transplant survival. Briefly moving on to what do we use for immunosuppression. We use calcineurin inhibitors, cyclosporine, tacrolimus. The mTOR inhibitors are the new kid on the block. We are using them more and more. Antimetabolites are a standard therapy for suppression of the bone marrow. And then steroids, of course, prednisone to be more specific. And then unique side effects. You have this on your handout. Remember this, picky, but they may ask you about this, the gingival hyperplasia with the cyclosporine, the glucose intolerance in the diabetic patient with tacrolimus. The boards love this, azathioprine and allopurinol combination, profound bone marrow suppression. People have died from this interaction early on. The mycophenolate, the CellCep mycophenolate with the gastrointestinal infection and a higher incidence of post-transplant lymphoproliferative disorder, and the rapamycin, the sirolimus, wound healing effects. So keep those in mind. Yellow bars represent the current day era of treatment, and that usually involves the use of tacrolimus, mycophenolate, and prednisone. Those are the kind of the triple therapy. How much immunology you need to know? Well, I hope it's not a lot, because even after 15 years of doing this, this is always hard to wrap your head around it. But just basically, we do screening of the patient's blood for antibodies, either using the PRA or the single antigen bead. And then sensitization events are usually blood transfusion, surgeries, other things like that. And women, of course, multiparous women tend to have the highest risk. So those are things to think about. And then you can get a calculation of the patient sensitization to HLA that really determines our ability to pick up those patients who are not going to do well unless you do HLA matching. That humoral rejection is B-cell or antibody-mediated rejection, and hyperacute rejection is usually due to incompatibility of high PRA. Cardiac biopsy, T-cell mediated or lymphocyte mediated, and you treat it with steroids, pulse steroids, IV steroids. That's the biopsy. These are the new classification, and I think the important thing is you're going to treat more moderate or severe rejection. That's what it looks like. Here's the severe rejection, a lot of lymphocytes and myocyte necrosis. And you're going to treat it with IV steroids. The humoral rejection, moving on to antibody-mediated rejection, it's either not there or there, and you're going to treat it. The difference there is you'll still use steroids, but you'll filter the blood for the antibodies, and you'll use agents to treat the B cells antibody production. That's an immunoperoxidase stain, and you would see that antibody deposition around vascular wall. Complications of biopsy are a favorite of the boards, and I'm kind of coming on to an end here. This is a patient had a biopsy, returns a month later for a routine visit. Big change in the X-ray. That's a pleuropericardial effusion. We've seen coronary RV fistulas, and of course, 10% of patients tricuspid valve injury, thrombus in the RB from the injury of the biotome and PE has occurred, and then we can see transient arrhythmias as well. The common complications are listed here, which include, of course, rejection and graft-related coronary artery disease. These are the things I'm going to talk the most about. Infection prophylaxis includes prophylaxis for CMV, PCP or toxo, which you accompanied with Bactrim, and then antifungal on those patients who are at higher risk. That's in your handout. That's a patient with herpes zoster, very common complication, one we see quite often in patients. That's a patient with fever lymphadenopathy, and that's a CMV inclusion body. And the clinical scenario of CMV is the things you want to remember: mismatch. So if the donor is positive, recipient, the person who's receiving is negative, that's going to have the highest risk. Presentation, fever, malaise, night sweats, and diarrhea. And you're obviously going to treat that with ganciclovir. When you look at complications over time, this is cardiac allograft vasculopathy, which I told you I would cover as well. As the years go by, the incidence of that increases. That's a very diffuse process. You see the tapering on the coronary arteriogram, relatively normal proximally, and then more of the what we call the pruning of the vessels. Intravascular ultrasound and pathological specimens, significant diffuse process. Those patients who've had coronary artery disease are at greater risk. Hypertension and other markers, diabetes, do increase your risk, as well as, a high degree of HLA incompatibility or history of rejection has also been associated with greater risk. Unfortunately, not a lot of great treatments. Sometimes you can use interventions for management of symptoms, and then statins and switching to rapamune, but retransplantation is not an uncommon scenario in those patients. We looked at patients with malignancy. Another common thing they may ask you about, lymphatic malignancy or lymphoma predominates in the first year. That's when you're at the highest immunosuppression. And then at the 2-year follow-up, skin malignancies continue to be most common thing we see. Here's an abdominal mass in an EBV negative patient. This is a typical presentation of a lymphoma. You see it in the pathological specimen, and also it can appear anywhere. So just very briefly, because I'm over time here, the EBV negative patients, those are Epstein-Barr virus negative patients, will be at the highest risk of PTLD, as we call it for short. It's a B-cell lymphoma. You have to reduce immunosuppression, and you see them most in the mediastinum, but you can find them everywhere, as I've already showed you. Renal dysfunction also common because of the therapy. Hypertension is very common. Renal dysfunction progresses with age, and you can see varying degrees of renal dysfunction, including dialysis. And lastly, just sort of kind of give you an idea of the timeline of these events in summary, and kind of wrapping up here. Graft failure tends to happen later, usually the result of development of coronary artery disease. As you can see, the incidence rising, and then the infection and the problems with malignancy are more of a problem early on during the high immunosuppressive stage. And I think we are going to wrap up and move on to questions a few minutes late, and thank you.
All right, so cardiac transplant and LVADs. Let's do these questions. A 45-year-old female was transplanted 3 months ago. 2 weeks ago, mycophenolate was discontinued due to diarrhea and anemia. She now is unwell, low-grade fevers, fatigue, and palpitations. She has right bundle branch block and intermittent high-grade AV block. She has severe rejection on biopsy. What should you consider? A, plasma exchange, B, pacemaker, C, steroid, D, angiography, E, rituximab. Good job.
This is the current answer. I think they got this pretty right first time around. So just very briefly. So again, what are the salient features here? 90 days ago. So this is early course, okay? And then we had to stop an agent. So now she's on 2 agents. Pretty early post-transplant, you have to stop one of the immunosuppressive agents because of side effects. And now she feels unwell. In the palpitations, now we're seeing a conduction abnormality, very common marker of rejection, intermittent high-grade AV block. And so I'm not surprised, even if you didn't have the biopsy confirm severe rejection, you're looking at using IV steroids. And I've already told you, it didn't matter whether it was a humoral rejection or antibody-mediated or T-cell rejection. First order of business is give the patient steroids, even before you have the biopsy. And then you can consider other things. You're not going to need a pacemaker. These things are likely to improve with resolution of the rejection. So I think it's another important point. You don't jump into a pacemaker. You can use something temporary, but this patient isn't going to need that. And unless you prove that this is antibody-mediated rejection, you wouldn't do plasma exchange. Again, too early in the process. This is something you would think about, coronary angiography that is, you would think about later in the process where you thought a component of coronary vasculopathy would be contributing, and this, again, reserved for antibody-mediated rejection. I think we can go to the...
Yep. Next question.
It takes a little while before it loads. Let's see if it... There we go.
All right.
No, We done that?
There we go. This is a 33-year-old woman with negative serology for CMV, toxo, EBV, underwent cardiac transplant 7 months ago. She did well, but now presents with fever, aching, elevated liver function tests, and leukopenia. The most likely cause is which? TB, toxo, EBV, nocardia, or CMV?
Do I have to bring it? Sure, that's fine.
I'll ask you that question.
The HF? No.
I'll ask about
Yeah, that's fine.
All right.
So I think this is a pretty easy
Nice lift.
question,
62%.
and I think I see division between EBV or Epstein-Barr virus and CMV. Is this before or after?
That's the before. The after is 80-something%.
Okay,
correct.
good.
Yeah.
So I think that the significance here is these are the serologies we look at. Toxo disease presents completely different. That is more like the typical toxo disease usually is cerebral involvement. And that's usually on bacterium prophylaxis. I haven't seen a toxo case. I bet Naveen hasn't seen one either. But EVB, just think about EVB and PTLD. I haven't seen clinical disease or actual mononucleosis in patients. The significance on EBV negative serology is the propensity to develop PTLD. Now, the constellation of findings, if you add it, mass is present in the mediastinum, then will point you toward PTLD disease. But CMV is the correct answer. This is a pretty typical presentation within the first year, probably off prophylaxis. Now, fever, aching, and the elevated LFTs are classic. I mean, that's really one of the things that you see with that. Now, I can see how the confusion would be because that sounds like mononucleosis, right? But in the transplant population, CMV is the predominant pathogen. And nocardia is a fungal disease that causes a skin infection, so that's going to show up as a more necrotic skin lesions. Could also be a possibility, but it would have nothing to do with the serology. It would be an immunosuppressed patient is also at risk for developing this kind of infection. But I think this is fair game for boards. Just think CMV.
Great. We'll go on and do the next one.
Yeah.
61-year-old cardiac transplant recipient, 5 years post-transplant, now with syncope, frequent non-sustained VT on the monitor. He has no evidence of rejection. He has akinesia of the anterior wall. The most likely diagnosis is which of the following? Humoral rejection, antibody-mediated rejection, transplant vasculopathy, cell-mediated rejection, or CMV myocarditis. 99%.
Yeah, and I think this is really, if I expect something to come on the boards, it would be something like this. Okay, no symptoms. So first of all, you never hear the word chest pain or anything at all that sounds like angina here because we don't see that. Heart's denervated. Very rarely would you see somebody who actually have pain. And then the syncope is an ominous finding on somebody who's 5 years out all of a sudden, and then it's having all this non-sustained VT. That's usually an indicator of ongoing ischemia, as it is the case in real life coronary artery disease. Your adenine biopsy was negative, and we don't really talk about ejection fraction, but we do talk about regional wall motion abnormalities. And this is unfortunately how these patients usually present. No warning signs or symptoms. All of the blue, they show up with either I felt more short of breath, EF is down, and then you see evidence of myocardial injury without any other kind of symptom for it. So rejection wouldn't be a focal process, so you wouldn't see akinesia on the apical wall because of humoral antibody-mediated rejection, which happens to be the same, or cell-mediated rejection. That's more of a global process. You would anticipate a fall in EF, globally reduced, and then CMV myocarditis is also not a focal process. It will result in a fall in ejection fraction, and it will have, of course, histopathological findings on the biopsy that would suggest that of concern. So the only real answer 5 years out would be the presence of vasculopathy, which is what this patient had.
Great. So one thing that comes up from time to time, Alfredo, is there a role for VADs in patients with preserved ejection fraction heart failure?
So in essence, there hasn't been any trial that has actually looked at patients with preserved ejection fraction, traditional HFpEF without other conditions. We have done a number of amyloid patients, restrictive cardiomyopathy patients, which are two separate entities, as Barry alluded to. It's not really traditional HFpEF who have done reasonably well with LVAD support. So, but that is not I mean, that has been outside of the indications for LVAD therapy. I will not expect the boards to say, yeah, you know, we have somebody with a restricted cardiomyopathy, will you implant a VAD? The answer would be no, because there's no data to support that approach.
Great.
And certainly in HFpEF as well.
All right. Thank you very much for the tour of infectious disease for cardiologists.